Welcome to the latest episode of Leadership and Culture in Healthcare. I'm podcast host Matthew Winn, and we are in our Series 7. We're in this series about clinical leadership, what it is, what it does, how do people do it. And I'm delighted I have Adrian Boyle. Many of you who listen to this in the UK will know Adrian from things that he's done over the last few years. So Adrian, let's kick off by people knowing a little bit more about you. What do you do clinically? What have you been doing that people might have heard of you nationally, and explain a little bit more.
Yeah, so I'm a consultant in emergency medicine at Admiral's Hospital in Cambridge, which is, it's a job, but my big role has been around being president of the Royal College of Emergency Medicine. And I did that from 2022 to 2025. I'm now what's known as a PIP, a previously important person. So I've basically gone back to my base job, having had this fairly exposed political role.
And tell people what it's like being the president of a college, and also just because yours has been quite a lot in the limelight because of the nature of our urgent care world and emergencies and really the highly charged political nature of those kind of targets in A&E and hospital handovers, etc. So give people a kind of view of what it's like to be the president.
So the college represents 15,000 members and employs a staff of about 60 people. And with 15,000 members, you've got 15,000 opinions, all of which are right. I mean, as a specialty, we are pretty forthright at the best of times. It is impossible not to have a role like this and suffer a degree of imposter syndrome. Particularly when you're vocal in the media and you do things which get attention and also sometimes upset people. So we made a big media splash and a campaign around the harms of long stays in emergency departments. And I will remember this day very specifically, January the 1st, 2022, I told Times Radio that the problems in emergency departments were killing somewhere between 350 and 500 people a week. That got everyone's attention. I was the center of a media flurry for ages, and I was being phoned up by senior people in NHS England, Department of Health and Social Care, ministers, eventually prime ministers, wanting to talk to me to explain myself. I got hauled up in front of the Health and Social Care Select Committee to try and explain, and it wasn't really trying to understand. It was actually a chance to try and discredit me. So I had to make sure before I said this, and we spent a long time preparing beforehand before we put it out, that we were absolutely secure in what we were going to say.
That's an interesting, well, it's a really live example because my recollection back, and my recollection from reading is that was pretty well evidence-based. It was data-driven. It was the experience of clinicians that were working in emergency departments. So this wasn't, as sometimes happens, a posturing position. This is real. We need to do something about it. And so therefore, did that solidity that you came from in terms of representing the views and knowing that this was real kind of mean that it was an easier thing to go through? Because I imagine that was pretty tough.
Yes. So I absolutely, before I put it out, because, the college has a reputation, we're governed by the Charity Commission. And if we are seen to be disruptive or not serious, or we could do an awful lot of harm. So I really needed to make sure that I was solid in this. Now, I had an advantage that I was a clinical academic before I became a president. I spent a lot of time doing research. I have a training in statistics and epidemiology. I have a doctorate in statistics and epidemiology. I know my stuff, but I was also spending a lot of time just making sure that getting diverse views, we were secure in what we were going to say, because we knew it was going to be an Exocet missile. It was going to make some people very upset. At the same time, being right isn't always just the right thing to do. We also had to consider the effect this would have on patients. And we spent a lot of time agonizing. If you shroud wave, if you're calling out something as not very good, what is going to be the effect on patients? Are you going to make people more anxious, more scared? And there was a real risk. We saw this in the pandemic. People got very anxious about going to hospital because they thought they'd pick up a dangerous disease, rightly so. But lots of people who needed to seek help stayed away. So we also had to consider the impact that this would have on patients. And we had to, this options appraisal, we weighed up the potential risks and benefits of us doing this. And you're weighing up all of that. And that's, for me, one of the key lessons about leading it. Your decisions are never completely obvious. There's always a trade-off somewhere, and you've got to spend some time anticipating those trade-offs.
And from that kind of clinical leadership perspective, I guess the tough thing is harm being created or harm happening in an A&E department because of long waits is a symptom that everything else around it potentially isn't working, i.e. there isn't the access into beds, or there isn't the access to home services, or there's not even the preventative services happening to avoid people getting into that place in the first of all. So it's not just that you therefore run up against a potentially a embarrassing political narrative or a national kind of NHSE. You're also making quite a big impact on other clinicians and other part of their healthcare sector, aren't you?
Oh, yes. And, one of the things we've got within the world of policy is who is the squeakiest hinge. I try and talk about it as a series of victim Olympics. Now, if you're an MP, the way that you view health is by actually the volume and the angst within your inbox. And within health, there is a victim Olympics. GP access always is absolutely the top of the things that voters worry about. It's common, it's important, everyone can identify it.
And it's because more people experience it all the time, whereas relatively few people in comparison go to A&E, thankfully, in that respect.
Exactly right. And also dentistry, NHS dentistry is problematic. We also know that elective waiting lists are also, and intuitively, I think my urgent and emergency care oscillates between getting onto the bronze position of the victim Olympics behind dentistry and GP access, competing with all the others. And you are competing against other clinicians. And I could definitely see when I would talk to other college presidents that they would go, oh, you're dragging all that attention in. And different colleges had very, very different approaches towards this. We were very vocal. The GPs were very vocal. You wouldn't often hear from the surgeons. They do their influence in a very, very different way. And that's not just related to the problems they're dealing with. They're dealing with important problems. They've got massively important problems, but they had chosen to try and gain that influence in different ways.
I'm intrigued, therefore, how your career had prepared you for that very visible senior clinical focal point leadership as a president. How were you prepared for that?
I've been very lucky. I worked abroad. I spent quite a long time after I qualified working in Southern Africa, in both South Africa and a variety of other countries, and saw what happened when healthcare is really on the margins and really, really quite desperate. I trained in a wide variety of specialties, and I think I was allowed, in a way that we don't necessarily allow our trainee doctors now, I was allowed to go for a bit of a walk in the woods, trying various different things. I was hugely privileged to be selected to go and be a health services research fellow, and that was doing a master's and that stat thing. I'm not naturally numerate. If my maths teacher from school is listening to this, he will be falling off his chair. But I ended up doing a degree in statistics, and that ability to think and interpret data is really important. We were very, very data driven as a college. Partly by the nature of the work that we do, we can frame it in a very data-driven way. I spent some time as the lead of my department. I anticipated this really badly because I became departmental lead in November 2019 and was enjoying. You can see all the problems that happened after that. I suddenly had to reconfigure and run my department for the pandemic. And I dealt with huge amounts of staff anxiety, staff angst, the well-being of staff during the pandemic was a huge concern to me. I was constantly impressed by how heroic some people were prepared to behave. But the change management we had to do during the pandemic was utterly extraordinary.
Mm.
So I thought I had a mix of academic and managerial experience going into this role.
And then thinking about the skills one needs to do this. So you just described a really interesting set of experiences, whether it's data, different clinical experiences, to be great at what you do clinically. But something quite different about then standing in front of a camera or sitting in front of a select committee and having to put forward the things. How does the president be resilient, skilled enough to do that? Because that's not what we train clinical leaders to do most of the time, is it?
No, and it was really eye-opening doing some media training. And I was put through regularly each year some media training, and I was shown all the tricks people were going to use. I was shown how to craft a statement. And there's a bit of me as somebody who's very data-driven and scientific that it makes me feel quite sad about the level of discourse we have within our media. There's nuance and complexity in a lot of things we do within healthcare. Healthcare is inherently messy and difficult, and the nature of the media is always to simplify. So I spent a lot of time trying to simplify things to the level that I could feel comfortable with, but not beyond.
Yeah, and that's really important to, otherwise those messages get really they just, as you say, that it's a space of competing kind of policies, kind of angst, and therefore those clear messages have to be bang on, don't they, to get the impact. So let's talk about what you were doing prior to you were clinical director or deputy clinical director for the A&E world and urgent care. Your thoughts, therefore, on what it's like to be that type of clinical leader? Because there are a few spaces in the NHS that truly work 24/7 flat out. A&E is one of them, isn't it?
Yes. I mean, we would say that, we need to design our service around where the patients are. That point is sometimes lost on people before and after the emergency department. So I was really lucky. I had an excellent senior clinical nurse and an excellent ops manager, and we actually bonded very closely during this. It was having that small team right at the top, and we spent a lot of time hammering out differences and building consensus in private. And during the pandemic, the big thing we had to do was communicate. We had to let everybody know what we were doing. Now, within an organization which is employing about 400 people, that's really difficult, getting your arms around that. And we spent a lot of time learning, failing, learning again, about the best way to communicate stuff. I don't know how you run Cambridge Community Services, but the all-staff email doesn't work for clinicians. If you don't give people time to read it, they're not going to see it. And
I would argue most of my clinicians, actually the primary communication is not through email because they're working clinically. I mean, my view has always been, would I want the healthcare assistant or the community nurse who's out and about in people's own homes, sometimes overnight until late, actually to know that the communication is coming by email? And of course the answer is, of course not. No one would think that's a good idea.
Exactly right. So we realized that actually different professional groups have very different ways of accessing information, and we tried very hard to tap into those. We had a lot of success with our nursing staff with a closed Facebook group. And we would do, certainly during the pandemic when there was change happening all of the time.
Yeah.
And I used to get really cross with the 5 email from NHS England saying, please act this immediately. This is the new guidance on PPE testing, etc., etc. We were regularly making sure we would have a weekly Facebook Live event, and people would go back and watch it. It felt the informality was necessary. But then we also realized that didn't work for the doctors. It also didn't work for the healthcare assistants. It didn't work for the porters. And if you're leaving one group behind, you're going to cause all sorts of problems. We had to think
Yeah.
very hard about how we engage our staff, particularly at the lower end of the pay scales, around engaging with vaccination when that came along.
Mm. Mm.
And we did all the things about trying to get people from within their peer groups to have those conversations.
And do you think that's a key element that we've forgotten really works? Because if it was true in the pandemic, and it was true at that point, and that variability and appropriate different routes, it's still true now, even if there's not that intensity of national must-dos and all those things, because we're not in a major incident. But what's your reflection on actually just normal BAU things that actually we need to be very much different, but learn from what's good?
So I think people underestimate the difficulty and the value of good comms. And there's a degree where you go, I've sent the email, it's up to you to know it. It's a regulatory requirement. It's in you have to do it. And I think, I mean, remember the pandemic was a very different time. People were hanging around at home, fretting, and actually probably was the time they were going to read their all staff emails.
Mm. Mm.
But I think you make a good point that we have lost a lot of the learning from the pandemic. There's loads of things we've learned that we've lost from the pandemic. And it's, I get frustrated with the glacial process of the legally driven COVID inquiry, because we should be doing a rapid thing. What did we learn? How can we do this better?
Mm.
How
Mm.
can we accelerate the good things? If you look at the way we use technology, the fact that we're doing this call over Teams pre-pandemic would have been very cutting edge. Now it's business as usual. But we're not doing that in healthcare.
Yeah. Yeah. So when you look at your area, and it's a complex area, you're receiving people, you've got blue lighting, you've got air ambulances coming in, you've got an immeasurable amount of walk-ins nowadays that perhaps didn't have so much before. When you look at that and think about the college world, what's your take on the simple transformative things? And you've just talked about accelerating change that you would love to see and pull off with more pace.
One of the things that we got slightly we as a college we pushed against is the idea of initiativitis. And we regularly commented fairly robustly, either pre-publication or directly after publication, around the various winter plans, the urgent and emergency care plans, because I don't think they're properly socialized in advance. They're not true collaborations. And I think there's a real challenge, and it's effort and it's time. But there is this thing where the process, the activity gets confused with progress. Every year we get a UEC plan, and we've fed back regularly and they listened. But again, there's that political interference, which means every winter it comes out and everyone goes, how? What does this actually mean? How's it going to make things better? What can I get away? If you're a chief operating officer, you're going to look at this and go, okay, what am I most likely to get shouted about? What's my big priority? I've got to weigh this up against the elective plan, the cancer plan, the outpatient plan. Where am I going to put the effort? Which is going to be the biggest risk?
Mm-hmm.
And it's impossible for a coup to prioritize all of these things. If everything's a priority, nothing's a priority. So, we upset some people with our approaches towards the various plans, but that's because we wanted them to work. And we pushed people, and NHS England did buy this, that they needed to actually evaluate them. So they actually commissioned, after our nagging, NIHR, the National Institute for Health Research, to go and actually evaluate the interventions they were proposing. It takes time, but, real progress is small and incremental.
Indeed. And I'm in one of the episodes on this series is with the president of British Geriatric Society, and we were talking about there is so much good evidence-based research out there, evidence-based research to go together, hopefully, and some very clear guidance on actually how we should be dealing with and supporting people with moderate and severe frailty in a completely different way. I think the key thing is, and I'm sure you've got that in the emergency care world, the key thing is how do we then make the policy really take that into consideration and probably talk more about the how and the implementation and the stages to make it happen, rather than the broad brushstroke of this is barnstormingly sensible.
Yeah, and I could not agree more. And I think the implementation, you've got to understand the levers people use. If I look at the big implementations that have happened during my whole medical career, and I've been around a long time, NCPOD years and years ago said surgeons shouldn't operate on low acuity cases after midnight. It's unsafe. Don't do it. That worked and was taken up with a clarity, partly because nobody really wants to operate in the middle of the night. Even the most alpha silver-backed surgeon is not that keen to do things at 4 o'clock in the morning if they don't really have to. That was well aligned, and everyone went, great, let's do it. And now it doesn't happen. Going back again, 2005, implementation of the 4-hour access standard. Most people call it the 4-hour target. The implementation of that was some pretty fierce and pretty blunt and potentially harmful regulatory financial pressure on trusts to empty their emergency departments. We're nowhere near that level now, even though we've still got the same standard, and nobody ever takes standards away. They only add on to them. We've got standards right across the NHS which need to be archived and frankly put into the world of archaeology. But no one ever does that.
No. And so just traversing back then about that influence from the college, it's fascinating, isn't it? Because the college itself probably doesn't have power. Now I'm going to maybe change that. Direct power to change the way that the NHS works. But I guess my take on it has huge influence. It has huge indirect power because A, it represents, as you say, 15,000 people. B, has the clinical voice, because if the college says, and the college is part of the training and everything else, say this is the way to do it, then you get more chance of 15,000 people actually standing in step to actually do that. So that's an interesting juxtaposition, isn't it, from a president and a college to be able to think about how they exert the influence to make meaningful change.
Yeah, exactly right. So colleges have no real power. As president, the only little power I had was if someone was naughty, I could take away their diploma. And I don't think it's ever actually been done. And it's a tiny, tiny little thing. And you feel like when you start this role, you feel like you have a lot of accountability, but no levers to pull. And we spent a lot of time trying to bottle that influence and understand how we use that influence wisely. To be slightly technical, we drew up an influence and interest grid, and we got down to the level where we were actually identifying individuals within NHS England, GHSE, who we needed to go after, and we needed to engage with and make sure that we had regular conversations. And government doesn't help itself with this. Government is so complicated. If you look at the decision making within government, you have DHSE, NHS England inform them, there's the Cabinet Office, there's the Treasury, and there's number 10. And we would regularly go to meetings on the same day with people from different parts of all of those organisations. And the best you can do in a scenario like that is make sure that your messages are consistent.
And that's interesting, isn't it? Because it's the hidden world of decision making. I think the Secretary of State, the current Secretary of State, has talked about that, hasn't he? That he was slightly blindsided by the fact that when he came into the role, it wasn't just his decision to say, I want to do this. He then had to get Treasury approval. He had to get the Cabinet Office sorted out. And because one of the things I think he wanted to change, which was around general practice, it was politically really important that number 10 supported that. And therefore, your point is, if you're having to navigate influence to make that happen, it's on all of those facets. It's not just one dynamic.
100%. And, actually that listening to that and thinking about what I was going to say before I came here, it is really interesting. You walk into an environment like this, a role like this, and you realize immediately that list of things that you wanted to do is really hard to do. And you're not the expert. And one of the key things about leadership is you've got to recognize when you're not the expert. And that means, particularly in things like medical education and training, it's highly regulated and it's very, very technical. And the processes they have to implement change are extremely complicated and shared between multiple organizations. So, yes, absolutely. I mean, I think you can create the influence, you can create the problem, you can absolutely make sure everyone understands it. But again, simple messages repeated repeatedly, again and again and again. We used to call it the Archem broken record of the message that we would say.
Yeah.
And you keep having to do it. We constantly get told the problems in emergency departments are because too many people are going in. It's not true. It's never actually been about too many people going in. It's not enough people going out and spending too long before they go out. It's all around the flow and the exit block and the inefficiencies within hospitals and the difficulties of coordinating community care. That's where the problem is.
Yeah.
And if we don't say it, if we wait 6 weeks, somebody will come up with an initiative to say, oh, we're going to send less people to an emergency department, at which point my eyes roll and a little bit of my heart dies.
I guess just one push on that, I guess, is there have been some of that. And again, some of the people in this series have talked about seeing things in terms of the risk of the person involved. So what a better articulation of that is, a 95-year-old, their nature of risk and what is important to them, especially when one thinks about deconditioning in hospital and the negative impact on their mental health and etc. being in an alien space. It does, I think, need to force us to say, actually, it's not just the risk from the clinical perspective. We need to say, actually, sometimes it's the personal perspective over trumps that, because just because we can do it doesn't necessarily mean we have to do it. And I think that does mean sometimes that we're over prescribing how people are eventually getting funneled into emergency care when actually we're not giving them clinically massive amounts of change, are we?
100%. So I would absolutely agree, particularly around patients who are resident in care homes.
Yeah.
Care home residents get a very poor deal. They often are brought to emergency departments for very low value care that adds very little other than lack of privacy and dignity. Those people are very disadvantaged. But if you look at the long stays we've got in our departments, they're an important part of it, but they're not, in terms of volume, a big part of it.
The complexity is great, but it's and also the for them to be turned around and go back even to a care home is probably so much more time consuming than it is just for any other individual in there. Yeah.
So we always talk about we recognise that as an emergency department, we are possibly the squeakiest hinge, but we are very much a part of a system. And I think it's really important that we are curious about what happens before us and what happens afterwards.
Yeah. So you mentioned earlier, which I was taken by, when you trained, you were given some great opportunities to understand and experience other types of healthcare intervention, other type. You went to different countries, but you also had that broad thing. You also did your statistics world and everything else. And you said that it's not likely to happen now. Just help us understand that a little bit more, because it does go to the heart of, are we training our future clinicians in the right way for modern medicine and to be equipped to lead in this kind of modern era, this very digital savvy era, expectations going through the ceiling? What's your take on what we're actually doing at the moment and where that perhaps needs to be improved?
Okay, so what I was given was a chance to meander. Now, there are doctors who do take meandering courses. I work with some really interesting doctors who have dropped out of formal training programs to pursue alternative careers alongside their medical work.
Mm-hmm.
It takes a lot more effort and a lot of more organization for those guys to do it. One of the drives we've had, UK medical training is the longest in the world in terms of years. It takes, if everything goes absolutely swimmingly and you work full time, which no one does now, it takes you 8 years, start to finish. If you never fail an interview and you never fail an exam, from leaving medical school to become a consultant emergency physician. You go to the States, they do that in 4 years. They're really unhappy that it takes them 4 years because it used to be 3 years. Canada
And
also does it really quickly.
and so your take on that is why do we need 8 years then, as opposed to 4 to 6 years, for instance?
Well, some of this is around clinical exposure. We have the European Working Time Directive, so hours are capped, and you do need a certain amount of experience to see all these things. But we also train our doctors to a very high level, not just in the clinical care, but actually in quality improvement, in research, in clinical governance, because we train them rightly to be able to lead their services. And having that knowledge, if you go to, I've did some work where American doctors were saying, as a college, could we come and get approval to work in the NHS? A lot of experienced, clinically excellent doctors. But if you dig around, minimal research, no quality improvement, no real understanding of how clinical governance works. They work in a hospital system that only wants them to do clinical work. And I don't think that's good for, I think one of the strengths of the UK system is that we are good at nurturing and developing clinical leadership.
And is it then a systemic issue about how we then plan for great clinical leadership to flourish and take responsibility? As you described earlier in your ED department, you work hand in glove with nurse leaders, general managers to do things. That's not always true, is it? So if we're doing such a good job, which I think we are, don't get me wrong, on getting clinicians to be really multi-faceted skills, then we still need to create the opportunities and environments everywhere for that to flourish, don't we?
Yes, and it's really difficult because some places, as you've hinted at, particularly in the small and remote and challenged areas, they have overwhelming challenges to deal with. And, there's always a health inequality around this, that rich areas with nice, big, shiny hospitals will always attract the high-profile doctors. I'm hugely privileged to work in Cambridge. It's a great hospital. I work with some fabulous colleagues, both in my own department, but also in the main hospital. That's not routine. And the question is how we might actually try and tackle some of those inequalities. One of our college campaigns was around equal access to emergency care and equal access to trained emergency care. We looked at the ratio of emergency physicians to attendances. It ranges from 1 consultant per 3,000 attendances to 1 to 30,000 attendances. You can go to some very remote places on various islands. There may not actually be somebody who's got a training in emergency medicine looking after you when you go to a department.
Yeah, and so those dynamics are vastly different. And it's interesting, other countries which have got much bigger terrains than we have and much bigger geographies have started to do that very differently as well, haven't they, because of necessity?
Yes. So, by example, in Canada, you can become an emergency physician in 2 ways. You can train in an emergency department, doing something which looks very much like the training we do here, or you go and be that remote and rural general practitioner in Canada. You are given a skill set which doesn't look too dissimilar to what GPs in the 1950s were doing: cesarean sections, cholecystectomies, appendectomies, deliveries. Big skill set.
Yeah, very probably.
Sounds fun, but terrifying at the same time.
Well, exactly. Yeah. So, Adrian, as we think about what's next for you, you've had a long, intensive career in terms of you as a clinician and consultant. You've done your national role. You're now supposed to being a famous person, as you described, which I'm not sure is going to be true. What's next in leadership? What would we expect from Dr. Boyle going forward?
Okay, so I am taking a deliberate decision to step back for a bit and actually reconnect with being a clinician and teaching my residents, being a good colleague to my consultant colleagues who've actually been incredibly accommodating with me, sort of dropping, saying, I need to go to this meeting right now. So I'm going to reconnect with that a bit and actually just process it, because it was so intense that I do just need a bit of time to reconnect. I like policy and I like working through knotty policy problems. I'm continuing to do my research work. So in a way, I think I've just gone back to being an emergency physician again.
You said you're of course part of that is training. I imagine you do your fair share of training, of I'm sure a multidisciplinary training, not just the medical training. But what's your advice? What's your reflections as we come to the end of this about what you say to people in training and listen to this and thinking, yeah, that's what Dr. Boyle talks about. Is that's me in the future. What's your salient advice to them as they kind of progress along that route?
So I think it's important that they lean in. I really would encourage people to. I have enjoyed being college president immensely. It has been the most professionally satisfying thing I've ever done. It is impossible not to be a little bit wowed by walking through the doors of Downing Street, and being asked direct questions by very, very senior people. It's wonderful. I would really encourage people to lean in and engage with this. But I would also say, make sure you have skills. Make sure you can actually do something good around data, good around media. Make sure you've actually got some credibility and actually have some of that leadership that you acquire in your own environment. Because actually, a lot of the questions I got asked with at macro level, at departmental and policy level, were actually just reflections of what I was being asked at lower level. So a classic example, I would be regularly asked by my chief operating officer, what's going on with productivity in your department? Can't you make these guys work a bit harder? Look at all the money we're spending on you. I had exactly similar conversations with very senior people at NHS England going, what's going on with productivity in your specialty?
And you just took
having that
second
critical grounding, that leadership grounding at a local level was helpful to respond to that at a senior level.
Yeah, and I think it's a very salient point about that grounding and that expertise, isn't it? I've done quite a bit of training with people who are either wanting to be a director or actually become a chief exec, and I have to say, always the one thing I've said to people is don't be in a rush to get to a position, because you need to know your trade. If you're not good at your trade now, you definitely won't be good at your trade doing something else, because you've just missed out on the opportunity to get the experience that holds you in great stead to do the next thing. So actually, you still need to do it, don't you?
Yes, and but also at the same time, while you're doing it, you need to be looking to bring people along. So we had a mentorship scheme within the college, and that was really successful. I would bring along with me to these big meetings our resident representatives, and they would you could see them going, oh my God, I'm walking into the Houses of Parliament. Lots of people walk into the House of Parliament every day. It's not actually that special, but actually it really encouraged them, and it saw how stuff was done.
Yeah. To get those glimpses, get those, even if it's short burst things, actually just be that cushion that kind of takes all that kind of experience and store it up for the future. And final thing then, Adrian, what are you looking forward to? You said you're stepping back, you're recalibrating, you're thinking about what you've done. You've still got. I'm intrigued. You still like your policy. So my sense is we still haven't seen the impact of you being president and some of those things. It sounds like there's more things that you want to get sorted from a macro and micro level.
Yes. So I chair something in the college now, and I've gone back to doing stuff in the college, and it's slightly odd to do something in the college where you've actually got taken a lesser role, but I chair a guidelines committee called Guidelines for the Provision of Emergency Medicine Services. And the idea here is to set out service specifications for what an emergency department should look like. Because, on a slightly prosaic level, we need to build good fences to get good neighbours, but also our managers, our chief operating officers, our execs need to know actually what an ED is and what it isn't. Because, if we don't, we'll be told what it is. So I'm chairing that piece of work. And that's quite a big piece of work. I'm also supporting a number of parliamentarians. We've done our first report on exit block for the APPG. So that's an all-party parliamentary group on emergency care. So we're probably producing somewhere between 3 and 4 reports a year about various hot issues. The one we're working on at the moment is around mental health. We do crowding. We'll probably do something on children later on.
And you need enthusiastic MPs to get those things done, and peers, because it's both parliamentary groups, aren't they, in Westminster?
Yes, and going back to my influence grid, we noticed that there was an MP who used to be an emergency physician, so that was helpful. And then we also noticed there was a peer whose daughter was an A&E consultant. So we spent a lot of time looking for stuff like that.
Adrian, it's been fascinating listening and chatting to you. That kind of real experience you brought and you described about developing over many years, consultant in the Edinburgh's world, but that experience internationally, a really impressive and fruitful time representing your peers as the president of the college. And I think you described really well about that influence, that tactical and policy driven approach that you have taken as a college to actually do things, talk about implementation, and know that actually this is a tough area to influence nationally, both politically and in policymakers, and sometimes you need to be super adept at how you do that. And you described how the college has done it, and then finally you've kind of given that really impressive kind of thing for students, for people training, saying get involved, don't be a bystander, get involved in that research, get involved in the college, get involved in things, and experience that change, because who knows, 5, 10, 15 years you could be president as well, making the same impact. It's a fascinating world, isn't it? It sounds like you've really enjoyed it.
Oh, 100%. It's been the best job that I've ever done.
And soon to be superseded, hopefully, by making change from a different angle in many different ways for the rest of your career. Adrian, thank you for spending time talking about culture, leadership, and clinical leadership on the podcast. We appreciate your time.
It's been a blast. Thank you.